peptic ulcer disease are ulcers of the stomach and the duodenum. I want to talk a lot about peptic ulcer disease in general, and then we'll talk about two specific causes, H. pylori and the gastronoma. Let's talk about peptic ulcer disease in general. As we said, there were two locations that these are found. It's going to be either gastric or duodenal. Gastric ulcers are usually associated with H. pylori, and duodenal ulcers are almost always associated with H. pylori. There are 5 kinds, or 5 major etiologies I want you to know about. H. pylori is by far the most common cause. NSAIDs, malignancy, and then some of the rare ones that you'll probably see on your test, but you're not going to see a whole lot of in life. It's going to be the curling ulcers, Cushing ulcers, and the gastrinomas, Gastroenterology syndrome. Patients are going to present asymptomatic in 20% of cases. And instead, these 20% are going to present with the problems the ulcer cause. This is going to be GI bleeding, perforation, and gastric outlet obstruction. But for those patients who are symptomatic, what you should look for is a gnawing epigastric pain. That is in some way related to food. If it's made worse when they eat, that is suggestive of a gastric ulcer. If right when they eat, the pain gets better and then they hurt 2 to 5 hours later, that's probably duodenal. Now this makes intuitive sense, but it ends up not being very true. If someone ingests food, gastric acid will be secreted in order to digest that food. If the ulcer happens to be in the stomach, now the ulcer is exposed to acid, so it hurts right away. If instead it's duodenal, all the contents, including the gastric acid, is stuck in the stomach, and only 2 to 5 hours later does the food leave the stomach and enter the duodenum. That's when the gastric acid reaches the duodenum. So it makes intuitive sense, but in reality, the history is insufficient to determine the location of the ulcer, so you can't use it. You might still see it on a vignette, but know that in real life, they do not correlate. Instead, to know where they are, you have to diagnose them officially. You do that with an endoscopy and biopsy. The endoscopy allows you to rule out malignancy, rule out H. pylori, and then give you a look at the ulcer, because you can look at the ulcer and kind of know what's going on just by what you see. For example, NSAIDs are going to be shallow and multiple. So if you see multiple shallow ulcers and a history of NSAID use, it's the NSAIDs. If you see big heaped up margins, and these are the things that cause gastric outlet obstruction, heaped margins and necrotic centers, think of malignancy, right? That's the cancer that's growing and outgrowing its blood supply. It's getting really big and nasty and angry in the middle. If you see a single ulcer, it could be H. pylori, and you really can't tell the difference between an H. pylori and a new malignancy, but once it starts outgrowing its blood supply and it's really big and nasty, they obviously look different. And still you can use the history for these others. The curling ulcers, think of a curling iron, and curling irons are hot, so these occur in burn patients. The Cushing ulcer, you want to cushion the brain, cushion the squish. So these are ulcers that occur with increased intracranial pressure. Cushing ulcers also happen in people on steroids and on ventilators. And these are the patients you want to use gut prophylaxis in. That is, feed them as early as possible, even with NG tube trickle feeds, or put them on a PPI because they develop ulcers in hospital. And the gastronoma is the refractory ulcer, usually multiple, with diarrhea. We'll talk a little bit more about Zonger-Ellison in a minute. Okay, so you said, okay, I thought this guy has an ulcer, you did an EGD, there it is, there's the ulcer, it's not cancer, what do you do about it? Well, to treat all ulcers, what you want to do is stop smoking and stop drinking. While these are not independent risk factors, they certainly make the ulcers worse and they impair healing. The same thing is true of stopping NSAIDs. Now we know NSAIDs is actually a cause of ulcers, so stop those as well. But no matter what ulcer you have, if you've got an ulcer, that ulcer is made better symptomatically and clinically by a PPI. You can hear the words acid suppression therapy. That's true. Any acid suppression therapy is going to work, but PPIs are better. Specifically in the case where you have to resume an NSAID or say an aspirin. The person had an ulcer, they got put on a PPI, they're given time to heal, what do? The answer is stop the NSAID and stay off them. But you can't always do that. So when you have to restart the NSAID, you put them on PPI prophylaxis. So it's a high-dose PPI to treat, and then a low-dose PPI for prophylaxis. And PPIs are better than H2 blockers, sucralfate, misoprostol, etc. Those are old school stuff. The new school is just to use PPI. And those other things will come up when a person becomes PPI intolerant. All right, so let's work through how you're going to work through the flow of someone with a peptic ulcer disease. They're either going to have the signs and symptoms of peptic ulcer disease or one of the complications, perforation, bleeding, gastric outlet obstruction, and you're going to eventually end up with an endoscopy. And if they've got the history and the EGD findings to suggest NSAIDs, you're probably still going to do a biopsy because you're in there anyway, which you don't have to. We know that you stop NSAIDs and give PPI. First, it's going to be BID, and then for prophylaxis, daily. If, on the other hand, you don't see that particular history, you do want to make sure you don't have a cancer. So even if it looks like an H. pylori ulcer, you want to rule out cancer. So you use the biopsy and pathology results. And that biopsy is going to show you this is very clearly cancer. That's malignancy. And you remember that malignancy is increased likelihood with heaped up margins and necrotic base. It might show you H. pylori, in which case you are going to treat the H. pylori. We'll talk about H. pylori in just a little bit, but the answer is triple therapy. Or it may show you nothing, and then you just have a regular old ulcer caused by something else, and you treat it with PPI. Malignancy, stage, and treat. We're not going to talk about gastric malignancy here. Now realize how often PPI comes up. And by the way, triple therapy, as we'll learn, involves a PPI. So it's PPI, 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 PPI. Proton pump inhibitors are how you treat peptic ulcer disease. If you have to choose one medication to treat peptic ulcer disease, it's a proton pump inhibitor. But also know the nuances and be able to identify the etiologies based on the EGD findings. Okay, so that's peptic ulcer disease, gnawing upper gastric pain, EGD, PPI. Let's talk a little bit more about H. pylori in particular. H. pylori is just an infectious organism. And most of the world is infected. About 50% are exposed. But most patients, about 85%, are asymptomatic. A small number of patients will present with dyspepsia or peptic ulcer disease, and a very small number will present with cancer, maltoma. So the idea here is that H. pylori is more than just an infectious organism, it's a carcinogen. And if you have maltoma and you treat H. pylori, the maltoma gets better. If you treat the H. pylori before they develop cancer, they never develop cancer. So it is a big deal. Infection is very common. Most of the time it does nothing. And so then what do you do? Or how do you suspect H. pylori? What it's going to come down to is the diagnostic step. If you find somebody who's got dyspepsia, then you're going to try to diagnose them with H. pylori. And there's a couple of tests you can do, and this is where the test is going to go. When do you do which test? When is it useful? Each one of these tests, serology, urea breath test, stool antigen, and EGD with biopsy, have a particular use. Hang on to that. If you ever test positive, what you're going to treat with is triple therapy. Triple therapy consists of clarithromycin, amoxicillin, and a PPI. Amoxicillin can be replaced with metronidazole if penicillin allergic. The other option is quadruple therapy, and it's in your notes, and you may have to know it, but the right answer is going to be triple therapy, so I'm putting triple therapy up on the board. If any of these become positive the right way, triple therapy. What does become positive the right way mean? Okay, so each one of these tests has a given utility. First off, EGD with biopsy is by far the best. And people usually get this because they investigate for GERD or dyspepsia or an ulcer, and they find it, they biopsy it, and then they are allowed to see if it's there. Now, EGD with biopsy allows you to diagnose H. pylori in one of three ways. I'm going to say them, I'm not going to write them, I'm just going to say them out loud. The first is the rapid urease test, which is literally done in a jar in the endosuite. They just plop the tissue in. If it changes colors, it's positive. That one's good, and it's nice to have the answer right away. On the other end of the spectrum is the culture, which takes a long time to come back and is not very useful and is very expensive, so don't do the culture. What is useful is histology. Seeing the organism on histology is sufficient to say that's an infection, treat it. So if you have to pick beyond endoscopy with biopsy, pick histology, not culture, not rapid urease test. The stool antigen is good for eradication. That is, after you've treated them, get the stool antigen and make sure it's gone. And I've saved these last two for last. That was on purpose. It used to be the serology was a miserable test because, after all, if you've been exposed, you're serology positive. And so even after you've been treated, your serology will remain positive. So why can you use the serology? Well, it turns out that it's actually cost effective to take someone who has symptoms, and if they test positive for serology, just to treat. That is the test and treat method. In order to do that, they have to have previously not been treated, otherwise the serology means nothing, and currently have symptoms. Never been treated before, has symptoms, positive serology, just treat. Don't need any additional tests, just treat it. But after you've already been treated, serologies are no longer useful. The urea breath test is good for initial diagnosis. It is very rarely done because the patient has to be off a PPI in order for it to be done, and most of the time we either use serology or endoscopy. But know that the urea breath test has utility in making the diagnosis. The stool antigen is useful for determining eradication, and the ultimate test is endoscopy with biopsy. All right, moving on to Zollender-Ellison to round this out. Back in. Zollender-Ellison, incredibly rare, therefore an excellent board favorite. The pathology is a gastronoma. Here's how a gastronoma works. Well, you've got this stomach. And here, at the end of the stomach, are these cells that stimulate gastrin. Gastrin stimulates parietal cells to make acid. In the presence of acid, these cells stop making gastrin. When there's no acid, gastrin's made. Nice checks and balance. But what happens when you've got a gastronoma? A gastrin-producing tumor, say in the pancreas, that regardless of the acid state of the stomach, makes gastrin. Now, no matter what this cell down here says, turns on, turns off, whatever, it's got an exogenous source of gastrin which stimulates these cells to make more and more and more acid. Lots and lots of acid leads to lots and lots of ulcers. So the pathology here is a decrease in the gastric pH, which is inappropriate. And so the patient's going to present with big, virulent, and refractory ulcers, sometimes with diarrhea. This is going to be the patient who has dyspepsia, who gets put on a PPI, doesn't get better, who gets in a scope. Well, look at all those ulcers, high-dose PPI, symptoms still persist. You get a repeat endoscopy, not that you normally do that, but because the symptoms are persisting despite really high PPIs, and you go, sounds like Zollinger-Ellison syndrome. The workup for Zollinger-Ellison syndrome begins with a gastrin level. A normal gastrin level is less than 250. That rules out gastrinoma. The really high value, I use the value of 1600, but some just say quadruple digits. If it's really, really high, you don't need to do an additional test. That's a gastrinoma. When it is between 250 and 1600, that is when you're going to pick the secretin stim test. You give secretin, gastrin levels go up, and that pushes you into the gastrinoma category. Then you have to go find it. If you're given the option between these two tests, I want you to pick the somatostatin receptor scintigraphy. Basically, it says, let's look for a gastrinoma wherever. And wherever there are these receptors, there's going to be a gastrinoma. Or the CT scan. Pick the SRS. The treatment is resection. And you resect it, one, to fix the ulcers, but two, because this is a growth stimulator for these parietal cells. You leave a growth stimulation on for too long, it could develop into cancer. So while Zollinger-Ellison, the gastrinoma itself, is benign, it can induce gastric malignancy. Okay, lots to know. Zollinger-Ellison, the gastrinoma, look for virulent ulcers that are refractory to treatment, get a gastrin level, then somatostatin receptor scintigraphy. H. pylori, memorize when to use serology, first time infection with symptoms, test and treat, urea breath test for initial diagnosis, not serology, stool antigen for eradication, and EGD with biopsy choosing histology as best. Triple therapy is better than quadruple therapy. And then for ulcers in general, look for the gnawing epigastric pain, diagnose with EGD, and put people on PPIs. That's peptic ulcer disease.